Good morning, and welcome to our what I call Crack of Dawn panel. The topic is centering equity, the precision data imperative, and the value assessment conundrum. My name is Gretchen Wortman. I'm Vice President for Policy and Program of the National Minority Quality Forum, and I am Director of our Institute for Equity in Health Policy and Practice. I'm joined today by four distinguished and experienced scientists and persons with professional and lived experience who bring a perspective to this issue of data and value that, in my view, is wanting. And so I ask you to be patient with us as we present to you, and then engage us in the question and answer period that will follow all of the initial presentations. My panelists, in the order in which they will present initially, are Dr. Heidi Waters, Senior Director for Policy and Research of Global Value and Real World Evidence, a really long title, for Otsuka Pharmaceuticals. Deepti Loharakar, an attorney and Senior Policy Advisor with Venable. Attorney Stephanie Monroe, Vice President and Senior Advisor for Health Equity at Us Against Alzheimer's. And Courtney Yo Savage, Senior Vice President for Policy and Advocacy of the Cancer Support Community. As I want to frame this conversation for you through what I will call the perspective of the National Minority Quality Forum. I don't think there's any question regarding how we define data, quantified, structured data in the United States or on the planet. But what is value assessment? And to whom is the value to accrue is what informs the conversation of the data that we need to bring to the conversation. So I looked for a definition of value that was not on ICER's website or CMS's website, because this conversation is not about ICER. This is a conversation about the different value assessment processes that occur in our environment, whether they label themselves as value assessment or not. And the definition I found that I think is sufficiently broad is value assessment advises, my quote's not there, whether a health service, a drug, a device, or surgery should be used, and if so, how it is used, how it is best used in the healthcare system, and which patients are most likely to benefit from it. And I think through the lens of equity, I would submit to you that one of the thoughts we would like to leave you with, whether we have an answer or not, is whether as we move forward into reimagining health services, research, delivery, and finance, as Dr. Puckrin has been speaking to it for the past 2 days and actually the last 20 years, is value assessment compatible with the concept of equity? Is it possible to tailor a value assessment process that is somehow equitable in its construct? And if not, how do we address what are the real systems challenges that have triggered and increased interest in value assessment, which is concerns about costs. And the costs that will accrue, must accrue, if we're going to bring populations into the center of the bell who have historically been allowed to exist in the margin. And so I would turn to Heidi and ask her to make her opening remarks. She's going to limit, each will limit them to about, I think, 5 minutes, we agreed and then Stephanie, Deepthi, and Courtney will make their remarks, and then I'll ask questions of the panel, and then I will turn to you. Heidi?
Thank you. Thanks, everybody. And I'm really heartened to see how many people are here today. I'm Dr. Heidi Waters. I'm Senior Director of Policy Research at Otsuka Pharmaceuticals. I sit within the Global Value and Real World Evidence Group, better known to most of you as the HEOR group. It is my function's job to do value assessments for our products. So please don't beat me up. It's an unfortunate part of the pharmaceutical industry that we have to do. And I know this conversation is not about ICER, but I would like to talk to you a little bit about the QALY for just a minute. The QALY is short for Quality Adjusted Life Year. I'm sure most of you know this. It's a very simple mathematical calculation that basically attaches value to a human life, which is problematic, I think. The QALYs started not in the US. They're very widely used overseas. We can't get our product approved overseas without doing a QALY, a cost effectiveness analysis. It is what it is. In the US, we've been a little not a fan of the QALY until ICER sort of came along and started promoting use of the QALY. And I get it. I get the need to attach a value to a medicine. But QALYs are inherently discriminatory. The way the QALY is calculated values a life year. So a year in perfect health is a 1, death is a 0, and everything in between is a matter of how sick a person is deemed to be and how valuable their life is deemed to be. So people in minority communities, seniors, people with chronic health conditions, people with disabilities, the QALY values their life less valuable. It attaches a value that's less than a perfectly healthy white person, to be honest. So it discriminates against a whole group of people right off the bat. The way QALYs are calculated, we use data from clinical trials because we need to have a QALY at the outset to get reimbursement for our products overseas again, but still we'll have groups like ICER who come and value our medicines in the US too. We know that clinical trial participation is underrepresented in minority communities. So we don't have necessarily the data to do sub-analyses of the QALYs to find out who would benefit most from our drugs or not. So we're limited by what data we have, unfortunately. But I don't want it to all seem like gloom and doom. There are a lot of good things that are going on in the pharmaceutical industry and in the groups that are my scientific groups, like the ISPOR, International Society for Pharmacoeconomics and Outcomes Research, and AMCP, the Academy of Managed Care Pharmacy. They have work groups in place. I sit on both of them, looking at health disparities, how to collect better data, how to use better data. And as a healthcare researcher by training, that's really what we need. We need better data. We're limited to what we have now. The other main function of my group is to look at drugs after they're approved and see how they perform in the market. My company makes antipsychotic and drugs for rare kidney disease. So for the antipsychotics, a lot of our patients are covered by Medicaid. In the Medicaid data sets, we don't get information about race or ethnicity. We're not allowed. They don't release it because it's a HIPAA violation. So we can't do the kind of analysis we would like to do to identify populations who would benefit most by our drug. But again, there's hope because groups like AMCP and ISPOR are really pushing better collection of data, better use of data. I know somebody talked about the All of Us data set yesterday. I would just like to plug that as a fantastic opportunity. My company has started looking at use. We're actually using the All of Us data set to evaluate PTSD and social determinants of health on PTSD. We worked with Kaiser to link our data set, or the Kaiser data for people with serious mental illness, to the TransUnion data set, which is a credit card company data set, to look at other indices of what we termed disruptive life events. So things like arrests and bankruptcies and liens that are not typically things we typically wouldn't look at as a pharmaceutical company, just to get a better picture of what's going on for our patients with serious mental illness. And we also looked at the effect of age, race, and gender on those disruptive life events. Will be published in JAMA Psychiatry fairly soon with those data. So we're pretty excited about some of the different data sets we're exploring to try to get at a better picture of health and in diverse populations. We've also done a lot of work to try to get better data encoding. So we worked with the National Minority Quality Forum and others to get ICD-10 codes for agitation in Alzheimer's, agitation in dementia, because if you don't have a code for something in my world, you can't measure it. So, so I would just like to leave you with a hope that we have started to collect better data. We've started to understand the need for better data and have started to create data set, not us personally, but the data ecosystem has started to create better data sets that will allow us to actually attempt to look at the social determinants of health and health disparities, and then better enable us to outreach to the populations of patients we treat, and hopefully improve access to medicine and the use of our medicines in the patients who need it.
Thank you, Heidi.
Thank you.
Stephanie?
Okay, I'm going to wake everybody up for a minute. That was a great presentation. This is a really big topic, and one that I think I wanted to spend a little bit of time taking us maybe to a different level. When I think about value assessment, I actually like to flip it and talk about the fact that we assess what we value, right? We assess what we value. There's a lot of data that is out there in the universe. Whether it's the right data or not, whether it's asking the right questions, and whether it's being applied correctly is a different issue, and is often determined by what we value, what's important. So I think about, I do a lot of work with clinical trials, looking at Alzheimer's disease as one particular issue. We've actually had some challenges recently of getting drugs that have been approved for the first time in 17 years to the market, based on CMS deciding that they were looking for a certain type of value that maybe they didn't quite trust that the FDA was the best body to be making scientific decisions, although they, unlike CMS, actually have scientists who make scientific-based decisions. So it's a matter of really, what do you value? What do you measure? So I'm going to use some of my notes here because I'm a lawyer and we could talk for a long time, and I don't want to go down that rabbit hole with you. But I think, from my perspective, I think about what are the populations that our system has been built to serve? Is it Black and Latino and underserved population? Those populations are underserved for a reason, right? I'm not trying to be a skeptic. I don't see boogeymen everywhere, but as my father once said, just because you're paranoid doesn't mean people aren't following you. The system is designed to serve a certain type of people. The system is designed to serve a certain type of people that are just well enough to benefit from medications and therapies. The system isn't designed really to cure things, right? I'm not trying to be sarcastic. Trust me, I love pharma companies. I really do. I love the technologies. I love the innovation. But let's look at the fact. The United States doesn't pay people to prevent illness. We pay people to keep us well enough, potentially, can I say it, to keep us well enough to continue to take medicines for the rest of our lives. That's how our system is built, right? And so who are people who can afford medications? Who are people who are, can I suggest maybe that we cream people based on their ability to benefit most quickly from medications, where there's not a lot of other stuff like life, chronic conditions, environmental concerns, stress. That's messy. If we were to actually include those populations in clinical trials, it would muck up the results because we're messy. So they've decided, whoever they is, the man, the woman, whoever it is out there in the ether, that we're going to serve and we're going to look at and build a system designed to benefit white men of European ancestry. And therefore, we're going to norm everything against them. We're not going to look at the Black population and see who's performing well, who's not performing as well, and what's the norm in this population. We're not going to look at Latino, people of Latino ancestry and make a determination of what's unique, whether it's biology in this population, and then measure them against each other. We set our value based on a norm that is, in fact, a very significant minority in this country. And everything will be measured against that. So that's the first thing we need to understand and accept, that we are normed to a minority of people who experience or have more opportunity to experience health in our nation. So therefore, that's what we want to measure. So then we look at these other inconvenient populations who experience life in a different way. Some based on genetics, some based on environment, some based on education, some based on stress, other issues that again muck up the outcome. And then we make decisions, and I don't know who makes these decisions, but I can tell you, for example, in the Alzheimer's space, we collect data. We know in the Alzheimer's space that the gene that they often use to identify a person who is more likely than others to develop Alzheimer's disease is called ApoE4. Unfortunately, that's not the gene that determines whether Black people are most likely to develop Alzheimer's disease. It's called ABCA7. Check people for ABCA7 because it's not the normed gene. So we make decisions about people who will receive medications, about people who will be included in clinical research, based on a white European gene that may not be the right gene for people who have the highest prevalence of Alzheimer's disease in this country. And I would gather that it's not unusual for other diseases and cancers or things of this nature. So we have the data. Do we have the will? Why don't we want to test Blacks for ABCA7 as a better marker and treat those patients? What is our motivation? What's driving that decision? Is it, I mean, certainly it can't be that we want to have classes of individuals who are at higher risk that we don't treat. That couldn't be the motivation. I hope it's not. But it certainly is that, again, it's messy. So out of one side of our mouth, we talk about value. We value all, right? And on the other side of our mouth, we talk about precision medicine. But we don't really want to be precise. You can't both be precise and generalize to the public. You can't really generalize when research only includes 5% of a certain population that may be twice as likely, 3 times as likely, make up 20% of the people with a disease like Alzheimer's, despite only being 13% of the population. And you only go after 5%. And when do you do that? After you have normalized all the sort of healthy people in And then it's like, oops, I did it again. At the near the end of the trial, you go out and try to grab some people to make it look more diverse.
Thank you, Stephanie.
You can't have a system that does that, right? If you value people and you value the people who are the sickest, those are going to be the first people you want to recruit in for your trial. That needs to be your plan. It needs to be intentional. And we know how to do this. There are companies in this room who have demonstrated that we know how to do this. Instead of doing what we know will work to get the people in that we should be valuing, we don't do that. And it's like on the way out, on the way to a trial closure, all of a sudden we decide we've got to run into a church, grab some people, screen them, invite them to the party. But then guess what happens? Oh my gosh, we have criteria that's set up. You've invited them to the party. You don't think they trust anyone. You bring them in, you say, come to our party. Oh, I'm sorry. 75% of you are now excluded from the party because you happen to be sick. You happen to have diabetes. You happen to not have health insurance. All these things that prevent you from really entering into the party. So let's commit, and I'm going to wrap up my time, that we will assess what we value. And that's the framework that we need to make these decisions from.
Thank you.
Thank you.
Well, I'm awake. I don't know about you. Deepti?
Thank you. Thank you, especially to my co-panelists here for their comments so far. So I think they will serve as a backdrop. What I would like to do is give you kind of a case study that kind of illustrates the points that they've made thus far. So as a senior policy advisor at Venable, I have the privilege of working with Gretchen and the Alliance for Aging Research and the American Society of Consultant Pharmacists on a project called Project PAUSE, which stands for Psychoactive Appropriate Use for Safety and Effectiveness. So we will continue to call it Project PAUSE. And so this coalition was convened to ensure that individuals living in long-term care settings who have Alzheimer's disease, dementia, and any other sort of neuropsychiatric condition are receiving high quality, patient-centered, appropriate care without facing any sort of stigma or barriers. So the crux of the issue that the project is trying to solve is that those in long-term care facilities with dementia who may benefit from antipsychotic medications, which have shown over time to treat symptoms that are caused by dementia, they may not have access to those medications just because of the way the current measure is set up. So the current measure, which hasn't been updated in 10 years, actually more than 10 years, I think, only really takes into account the inappropriate use of antipsychotic medications. And it's not really informed by clinical need or any sort of individual patient nuance. Instead, it's serving as a blunt instrument that merely captures the percentage of patients that receive antipsychotic medications without really any line of sight into whether that use is appropriate. So, in fact, even the Office of Inspector General for HHS had a report in May of 2021 that found that the current measure of antipsychotic medications really fails to distinguish between appropriate and inappropriate use. Really, it doesn't even identify inappropriate use. Really, what it's collecting is it's reporting the percentage of residents who use antipsychotic medications. So it seems like even a federal agency thus far has recognized that that current measure leaves something to be desired. Project PAUSE has developed a supplemental measure which would take that appropriate use into account. And to be clear, the supplemental measure is not trying to erase the measure that's there right now. We simply want to update it so that you're getting a more holistic picture of what's going on, and you're then able to hopefully provide treatment to folks that would work for their case. And additionally, there's a number of other barriers on the federal level to this issue. So first and foremost, there's a black box warning on antipsychotic medication, a blanket black box warning from the FDA, which was issued more than 15 years ago. So at that time, the FDA deemed antipsychotic medications to be harmful and therefore issued the strictest labeling requirements that they could mandate for a prescription drug. But since 2008, newer and safer antipsychotic medications have come onto the market, but FDA has not reevaluated the stance on black box warning. Furthermore, and I think this is why the supplemental measure that we're proposing is not getting traction, is that CMS has spent a lot of time investing in the narrative that antipsychotic medications are bad and therefore their use should be diminished or eliminated completely. So sticking to that and changing the frame of mind of the folks at CMS has proven to be really tough. Now, the impact of the deficient measure combined with, we'll call it regulatory agency stubbornness, has a real world impact, which has we've talked about here, but particularly individuals who belong to communities of color and underserved communities are affected. For example, we talked about how Black Americans, followed by Hispanics, have a higher prevalence of Alzheimer's and related dementias. And then the other issue with the measure, or the other impact of the measure, is that the current reporting mechanism doesn't really allow for variation between facilities. So, that can always does drive greater health inequities. So many skilled nursing facilities in a rural setting will care for older adults with dementia as opposed to an urban facility. So since the current quality scores report only the frequency of the use rather than assessing the quality of the care provided, it's really unclear if the quality score for a rural skilled nursing facility is illustrating poor patient care or it's merely reflecting the resident pool. So what can be done about it? I think, Project Pause is advocating for CMS to, in conjunction with stakeholders, develop a supplemental measure that'll take into account the appropriate use of antipsychotic medications. So as I mentioned, Project Pause has that measure ready to go, so it could at least be used as a foundation for that conversation to move that forward. We really do believe that this will allow for improved management of mental health conditions, prevent patient harm, prevent harm to caregivers, prevent caregiver burnout, and decrease the health inequities that are there. Thank you.
Courtney.
Well, good morning, everyone. I'm going to need a little help from you all because this has been a whole lot. So can we try that again? Good morning. Good morning. This is actually my favorite topic. And the reason for that is that I have a fistful of notes here because I could talk about it forever, and I'm going to try to stay on topic. What you just heard were examples of all of the ways that the definition of value is failing. It doesn't work. But I also want to point out that what you have also heard is 3 different definitions of value in the same healthcare system injected at different points along the way. We've talked about ICER. We've talked about the CMS definition of reasonable and necessary. We've talked about Medicare payment and how those incentives are structured around the care that your providers are providing you in the office or in the nursing home setting or whatever. We could talk about how under the IRA, we're going to be getting a new definition of value in terms of clinical effectiveness of the drugs whose prices are going to be negotiated. We keep trying. So I guess maybe that's a good thing. We're still trying. But people who write policy don't always get this stuff right. And so I had thought about taking you on, in a trip in my Wayback Machine to talk about all of the different policy decisions and how we got there. And I understand that my perspective of how we got there is through a very specific lens of, my upbringing and my privilege and my perspective. But there were conversations that were happening at that time. There were people who were left out of those conversations. But the history of the policy and how we earned it is part of the story. So, I think that we could go back and talk about the publication of To Err is Human and how we ended up with hospital never events. We could go back and talk about pay for performance and bending the cost curve. We could talk about death panels or the patient surveys that are widely thought to have contributed to the opioid epidemic. All of those places were places where our health policy, where our policy system injected a definition of value and established just one more of these points. But instead of asking the question, what is value, and stopping there, I want to encourage us, as we have these new opportunities, to not only ask what is value, but what is value to whom and why. And I think that we can do that. And I think that we are starting to get to a place where we can inject the answers to those questions into the process. You know, it's hard to, well, I'm gonna skip ahead. I'm gonna skip ahead to let me take you down the road, down the in my Wayback Machine. The one policy that I want to highlight is around physician payment, and how did we end up there, and how is it working, and how is it not working? In the quality payment program, which is what we're talking about, value is a product of measured quality over accrued cost. In this equation, quality is not some vague theory. It's measured using a sophisticated library of scientifically validated processes, structural and outcome measures, and some pretty defective patient reported outcomes measures. Cost is measured in dollars. Cost is not measured in anything else. Poor outcomes, poor patient experiences, those are not factored in, except to the extent that they result in more care and more cost. But higher value scores as a product of quality over cost result in higher payments for physicians. So they have an incentive to provide high value care. But CMS hasn't figured out how to make sure that everyone has to report on quality measures that are actually relevant to their practice. I used to work for cardiothoracic surgeons. If they are hospital employed, their hospital is reporting on a set of quality measures, you know, the easiest ones, the low hanging fruit, whether you did diabetic wound checks on a patient who came in, presented in the ER. Those things are easy. They're low hanging fruit, but they're not getting at the quality of care that that surgeon is providing. So again, this is the concept of value to whom and why. And what happens when this value construct in quality payment starts reaching the point of diminishing returns? My go-to example is a cup of coffee. My first cup of coffee in the morning gets me awake. I can't open my eyes without it. Second cup of coffee, I'm sitting down at my desk. I'm getting some work done. By my third cup of coffee, I'm probably getting jittery. I can't focus. If we keep layering, expecting quality to improve, not quality to remain consistent, but quality to improve, we're going to get to that point of diminishing returns. If we keep expecting costs to get lower, we're eventually going to squeeze out everything that we possibly can from the healthcare system. So how do you respond to that? You respond to that with innovation. That's what economists tell us, right? If Henry Ford was a surgeon, he wouldn't have been able to afford to build his assembly line because he wouldn't have been able to accept the upfront cost. So, you know, maybe down the line, we end up with Shelby, who makes some really fast cars, or, you know, a new treatment for colon cancer. But I'm betting that the family car, or, you know, the next innovation in rheumatoid arthritis never gets built because we don't have that efficiency. We don't have that opportunity built into the system. But we can insert a new definition of value to incentivize the addition of innovation that is consistent with our priorities, and innovation that is inclusive. So I want to leave you with that thought, but I also want to tell you that the science of measuring patient experience is here. It's not some ethereal concept. It's not patient-reported outcome measures. It is not quality assessment built into the Medicare physician fee schedule. It is here. Others are doing it. They're doing it to a certain extent in Europe. the Institute of Value and Innovation is doing it. My organization has the Cancer Experience Registry, where we are collecting data on patient experience and feeding that back into whatever process and whomever will listen. There was a paper published just last week by Avalier about triple negative breast cancer. And I am going to focus on my notes for a second because I want to make sure that I get this right. So triple negative breast cancer is predominantly seen in Black women, and it is vastly understudied. But this paper talks through how they were able to establish some new methodologies to incorporate not only collecting data on patient experience, but feeding that back into the healthcare system. Value is not experienced just in these measures that we've articulated. Value is experienced at the bedside. It's experienced in the ability to change your healthcare plan when you find something isn't working. It's the ability to be able to articulate as a cancer patient, I know that I'm probably not going to see the next 5 years of my life, but my real goal is to walk my daughter down the aisle in 6 months. How can we create a plan for that so that my treatment doesn't end up keeping me bedridden and unable to participate? My sister is a pediatric oncologist. She wanted me to add that value is not just in the experience of providing the best possible treatment to try to cure a young child who has a devastating cancer diagnosis. It's in having a treatment plan and executing that treatment plan with compassion so that even if that child dies, the family knows that their wishes were adhered to. That is value. And I want to convey that I think that we can get there. So it's not all hopeless, but we have a lot of work to do.
Thank you, Courtney. And thank you for listening. I think you've heard 4 very different experiences with value and data. I'm going to describe for you why the National Minority Equality Forum is here. We created the Centering Equity Initiative within our Institute for Equity in Health Policy and Practice in response to evidence that the current system of knowledge and intervention development, financing and insurance, and healthcare services delivery was not designed to create and sustain health for the full diversity of the American general public. And I'm going to add to that, that means it's not designed to really work well for anyone. It just works better for some than for others. So as we define our lexicon moving forward and towards a more equitable future, one of the concerns I have is that we're going to continue to measure one population subgroup against another. African Americans relative to Caucasian non-Hispanic, Asian Pacific Islanders relative to African Americans, whereas the system should collect data and enable application of that data to measure equity relative to the science, the current science and the potential of that science to improve healthcare and outcomes of care for everyone. Now, I'm going to put the money conversation aside for a minute, because the minute we start bringing cost into the conversation, we start editing our thoughts regarding what's possible within the current business model that is research, delivery, and finance. I'm going to ask us to set that aside for a moment and help us begin the conversation of thinking through the values that need to inform a reimagined system. The values that the Centering Equity Initiative brings to the conversation are a system of care that assigns the highest priority to patient risk mitigation, treatment and payment paradigms that provide clinicians with maximum flexibility in responding to patient needs, research designs that assure the statistically significant and robust inclusion of all population cohorts, and enhanced data collection, monitoring, and evaluation of the outcomes associated with promulgated policy and regulation. The panel last night, and I think other panels yesterday, spoke to social determinants of health. We did this morning. A concern I have is even that concept of social determinants of health has been skewed to only be understood within the context of those whose social determinants compromise their ability to access care, not those whose social determinants enhance their ability to access care. And as we, A, make sure that we're collecting the metrics that we need to have to move forward, but B, also assure that those metrics are being applied in such a way that we bring equity to our system, all of those social determinants have to be factored in. And I'm going to once again give credit to Daniel Dawes, whose text, The Political Determinants of Health, which I've renamed The Political Determinants of the Social Determinants of Health, speaks to the need to be upstream and understand that those social determinants, those negative determinants that we experience in community were either intentional or allowed. That the decisions that were made in the legislative and regulatory environments regarding those policies were aware of the potential negative ramification of those policies, and either intentionally or by operating in a blindered way allowed it to occur. And that's where not only do our clinicians, organized clinicians, I believe, have an ability to influence that conversation, but I'm also going to speak to the need for patient advocacy groups to begin to function in an equitable way. Because those of us who are excluded from, are not invited into research, are not invited into care, are also not invited into organized patient advocacy. And we all need to operate within the environments within which we have agency to move this equity conversation forward. So I'm gonna, if I still have time, the young man made me turn my phone on. A question for Deepti. Deepti spoke to Project Pause, so I'll start with you. You mentioned advocacy, Deepti, with CMS. Is there anything you want to add regarding challenges, well, success you may have had with CMS, or challenges associated with moving that conversation forward?
Yeah, and I was thinking about this a little bit more, and what I've realized is that this administration, particularly, I feel they've put it out there. We want patient-centered care. We've seen 1 million requests for information asking, that are based on health inequities. Information is being provided, but when it comes to something specific, like Alzheimer's patients who could benefit from a particular medication that isn't indicated for that disease, they seem to shut down. So we've had a number of meetings with CMS to try to explain to them why the appropriate use of antipsychotic medications is really important to take into consideration, the benefits it would have to the patient. And we've really hit a wall, and there is something internally that they just aren't willing to overcome. So I think it's sort of changing that mindset of CMS that they've now spent all this time advocating for basically eliminating the use of antipsychotic medications. To overcome that is very, very difficult. But we hear over and over again that Alzheimer's and related dementias, this is a very important topic for the administration, but what we're seeing is more and more stringent rules and guidance is coming out, instead of allowing a clinician to decide what's best for the patient and having the family and the clinician make that decision, based on science. It's not, people aren't just getting prescribed antipsychotics to, as CMS likes to put it, as a chemical restraint. That's not happening in the real world. And so the other thing that Project Pause is also working on is collecting testimonials from clinicians, caregivers, to try to prove that, because the data is very difficult to, it's difficult to mine that data to show that antipsychotics are benefiting folks, but we're seeing it every day. So I think we've had a little bit of a frustrating start with CMS, but we're going to forge ahead. And I think the other thing that we're also looking at is talking to the FDA about looking at that black box warning, because that is also creating a stigma around antipsychotic medications that doesn't need to be there. So we've got a couple of paths that we're going to go down. So appreciate the question.
And I appreciate your work, actually. As a company that makes antipsychotics, I'm not impartial to this argument, but we actually did do a study that looked at the effect of the star ratings on antipsychotic use in the nursing homes. And we found that antipsychotic use has decreased overall, but it's also decreased in populations where antipsychotics are indicated, like schizophrenia, bipolar disorder, and MDD. And we also went to CMS and met with the same response. Well, that's interesting, but there's no appetite politically to deal with that right now.
Yeah.
I think most of you probably know there was an FDA advisory committee last Friday. We have a drug that we are trying to get approved for agitation and Alzheimer's dementia. It's an antipsychotic. It's going to be very interesting to see what happens with the black box warning and the star ratings given that.
Yeah, and I'll just add.
Courtney and then Stephanie.
Oh, sorry. Go ahead.
I would suggest, and this is part of what I skipped over in my long diatribe about Medicare physician payment, but it is a system that is built on the premise that you can't legislate morality, but you can incentivize the behavior that you want to see. And CMS has not yet figured out how to create incentives without treating everybody without making everybody start assuming that everybody is at the same level. And so everybody needs this number of quality measures. Everybody needs to assume that the average cost of patient care is the typical patient, and anybody who is cheaper or more expensive is an outlier. And because we don't have, the tools are not intricate enough to be able to give them the feedback that if you provide care that is specific to the patient's needs, you are actually providing patient-centered care that is efficient and effective and not an outlier. But we haven't gotten there because they can't get their minds around everybody has to have the same number of measures, and everybody has to be counted. And when I say everybody, I'm talking about providers. I'm obviously not talking about patients, because we know that patients are not being counted. I thought that your comments about not only assessing who we're leaving out by I'll stop there. But, I think that when you start to create those incentives around patient-centered care and the individual definitions of value, then you get to the point.
Okay, yeah, Stephanie.
And I want to build on that, because I think, from my perspective, I want to make sure that we don't conflate equity with equality.
Yes.
And we often seem to do that in the healthcare system. One of the challenges is we should be providing patient-centered care. And what that means is that in order to create equity, where we supposedly give individuals and communities what they need, not sort of even the playing field for everyone, I just ask a question. I'm not like a professional healthcare provider or anything like this. I'm just a common sense person. Why aren't we paying people who are serving clients in areas of high prevalence, high need, high disease, high challenges. We should be giving those folks battle pay. Why isn't CMS providing more money to take care of populations that are sicker? We should be valuing, we need to look at costs. It's not just the cost of doing something, but the cost of not doing something, right? Because that costs us money, right? Whether it's caregiving costs, whether it's lost productivity because sick people can't work. We need to be evaluating that when we talk about costs. It's not that we don't have enough data. We got tons of data. We don't apply data in a way that makes sense for all people. And so that's our challenge in this century. I love researchers. We like to collect data, report out on it, but we keep doing much ado about nothing and not applying it and holding policymakers and others accountable to apply the data to do what we know. That's our challenge in terms of advocates. We need to challenge these systems that we pay, that work for us, to do what we need, not what's convenient.
Thank you, Stephanie. And I think, thank you. We're going to turn to the audience if you have any questions at all. I think there's a mic to my left. There's only one. Are there any questions?
Well, people are going to the mics. I would just advocate for that. Like I measure productivity, caregiving costs, things like that. Health plans don't care because it doesn't affect their bottom line.
Yeah.
So how do we raise our voices? We're doing those analyses.
But you know what? It does affect their bottom line because
Okay.
It should.
if I am too sick to work, I'm not going to be paying for health care.
Right.
Thank you, Stephanie.
I'm
We
going to
do
go
have
on
a
public
question.
health
We
insurance,
have a question.
probably.
Thank you.
Hi, my name is Ebony Megabo. I work with the Association of American Medical Colleges and the Center for Health Justice. And last year we did the maternal health incubator that started to interrogate these questions around like how is value assessed. And my question is, now that we have and have had the data on Black maternal death, Black maternal morbidity for such a long time, how do we contend with the fact that people are not assessing value on Black women's lives? That's a lofty question, I know.
I'd like the panel to answer, but I'd like to hear a little more from you first regarding what you think needs to be done.
Ooh, put me on the spot. I really agree with the notion and idea that we need to hold policymakers accountable. And what that looks like in practice is if you have higher rates of Black maternal death at your hospital, you should be not getting paid as much money. If that means that there are providers that you can like point to as having huge issues with equity in their population, there should be more of a value component in how we measure patient satisfaction and equity, if that makes sense. Like if you have a provider that you know is racist, then they should be penalized in their performance reviews. And that should like tie back into how and when people need to be dismissed from their jobs. Like if you have someone that's killing people with incompetence, then they should not get to keep their job. Does that make sense?
Okay.
So
Thank you.
I mean, and I'm not going to challenge you on the point of equating providing in bad care with racism. I certainly think that is underlying everything that you just spoke about. If it weren't, and we were talking about a different example, you just suggested, so if you're not providing good care, if you're not providing high quality care, and we have a system that is designed to measure quality, you said those doctors should be paid less. What if they're providing the best care they can with the resources that they have and they're serving an underserved community? Should they be paid more? And how do you adjudicate that? How do you decide? How do you decide? How to divide those resources? I'll give you an example from my previous life working in the physician world. I had an organization that had a very robust clinical data registry. They measured quality measures like it was their job. And they were very good at not only assessing provider performance, but also going in and helping underperforming doctors to improve. And one of the features that they measured in this database was a lot of socioeconomic data, including, and they've even started to overlay zip code as a proxy for all of the other socioeconomic variables that they think that zip code could be a proxy for. I'm not entirely sure that that was the healthiest thing for them to choose to do either, but they then have used this tool to calculate risk. And that does two things, or it could do one of two things. It could either make it so that those providers can take on patients who have more risk or are predicted to have more risk based on the data that demonstrates that people with these socioeconomic indicators have higher comorbid conditions and poorer outcomes. So it could keep those doctors from being penalized for any outcome that doesn't meet the standard because they're taking on that additional risk. Or it could be used to avoid providing care to patients who are high risk.
Thank you.
Which one is it?
Thank you, Courtney. I'm going to try to get two more quick questions and quick answers. Are those two people behind you at the mic? Or are you just standing against the wall? Okay. Okay.
My name is George Redmond, and I'm here representing a nonprofit. My nonprofit is the National Alliance Against Disparities in Patient Health. Mm-hmm. And I'm also the founder of the NIH Black Science Institute. And I also have a biotechnology company, a biopharma company that's developing drugs for cancer, another thing, infectious disease. My question is on precision medicine. Precision medicine is predicated on genomic science. By the way, for the audience, did anyone see the 60 Minutes presentation on Google and AI? Raise your hand. Last Sunday?
Okay.
Okay. I'll explain. You have a lot of data science that's going to be involved in developing precision medicine for the future. High computational science that's going to need AI. Okay, AI is predicated, the performance of it, on data science because it trains the algorithms to do the performance on the data.
So your question.
Okay, so my question is, we have to be more involved in developing the data science. If we're not involved, these algorithms will be biased in their performance. That will impact science, therapeutics, medical devices, the diagnostics. It's already happening. Recently for COVID-19, there was an oximeter that was developed on limited data to triage patients for COVID ventilation. Because it was not trained on a comprehensive data set, it adversely impacted minorities in terms of triaging them to go to ventilators. There's a study out on Google right now on it. These are the kinds of bias that are going to creep in to this technology once it's used in healthcare. And my concern is that we're rapidly moving AI into healthcare without really taking a serious look at how we're going to do the data quality or the data science that's going to protect our population. And that could result in more exacerbated health disparities in the clinic. So I'll stop there.
I heard a topic for another summit, actually.
Yeah.
I didn't hear your question, but what I heard from you was, how can we move forward at all?
Well,
without
I think
addressing these foundational gaps.
I think it's already happening. Like
Okay.
Mayo Clinic just did a study where they did a data quality survey that was capturing some of these social determinant data information, and they incorporated into the data science and developing the algorithm. And they found out that that was more beneficial in terms of really performance. And I think we need to start moving in that direction. We need to start building standards for data quality surveys that could be used for population, where that information can be included in the training of these algorithms. And we need to start now before the technology gets too advanced and too isolated to serve a certain population. That's my point.
Okay, so before you answer, I need to find, is there another question queued up? Or I didn't know if she was in the end.
Can I respond to that?
Well, you can. We've got 5 minutes left, so this
Okay,
is going to be
I'll
your
take 2
final
minutes.
statement.
So I
Okay.
think that's a great question.
Mhm.
I guess the short answer is, if we don't build with equity in mind, progress will always leave populations behind. And that's a problem. We have to build with equity in mind. Even telehealth and things like that, when you've got areas where they don't have Wi-Fi, they don't have cell towers, they don't have the ability to access telehealth, they're not at a certain literacy level, it's going to always leave populations behind. We have to be concerned about that. Do we want to slow progress until populations catch up? Probably not, right? So we've got to build with that in mind. Second thing about precision medicine. It's interesting to me that, and I'll talk about clinical trials for a sec. When we stand up a clinical trial with only 5% of African Americans, maybe 4 or 5% of Latinos, that's considered a diverse clinical trial. We then try to generalize that 5 or extra 4% to the entire Black and Latino populations, making ridiculous assumptions based on this incredibly small number, right? When I work with Congress and I talk to them and Representative Kelly before she left potentially about why don't we do some Black only or some Latino only studies so we can get a cohort that we can really study more deeply than being one of a few. We could ask questions like, well, that we would not really want to stand up a race-based study. Well, the response is, you already are standing up race-based studies.
Right.
No one's asking, you're not asking us if that's okay. So why is this a problem? When we find drugs like Vidal and others that we know from, because we have a large enough cohort that, my goodness, this happens to work better for Black men than it does for other people. And we decide, let's actually get this in the arms of Black men because it works better for them than white people. Controversy. Oh my gosh, you're marketing a drug for the population that actually might benefit from it. That's called precision medicine.
Yes.
If we did the same thing, right, and stood up a drug that was only studied on white people, but then we say it works for everybody, that's not race-based. I mean, there's just a lot of things, like I feel like we're schizophrenic as a healthcare system, and we know what we don't know know what we know, we don't apply what we do know, and we're expecting these outcomes. These outcomes have been designed. It would be silly, right, to think that they're going to be a different outcome than what we're seeing, because they're designed for those outcomes. And we're uncomfortable with race-based things unless it is to the current majority. What happens when Blacks and Latinos, as they are in at least 7 states, become the current majority? Are we going to be okay saying, or I actually did this Twitter, and I'll just stop with this, just to test all of my friends and people, and I asked a question, sort of a facetious question, how many of y'all would be okay with taking a drug that was only studied on 5% of white people if the other 95% were Black? Not only did I not get no's, I got no response. People were afraid to have a conversation about that inevitability. So we get the data, and then we're afraid to take the data to its logical conclusions. We're afraid to have public discourse around what this data is showing us. We not only suppress the data, we suppress conversations around it. And then those people who stand up to actually tell you the truth in data, they get poo-pooed. So we've got an issue with truth, and we've got to really pull back this veil and have honest, uncomfortable conversations that will help us facilitate change.
I would
Yeah.
suggest I could just
Deepti, and then Courtney, and then Heidi.
I just want to add to this in the sense of what can be done right now. So the Office of the National Coordinator has a request for information out about biases and algorithms. So I really, encourage people to flood their inbox with responses to that. That is one way to start making that change. they are required by law to read every single one of those responses. So, really get your thoughts out there on this really important issue. So just wanted to add that.
Thank you.
And
I would just suggest that everything that you just said about the development of science that is going to be the future of our healthcare also applies to policy. If we are not part of the process of building the policy, then we end up in the same predictable place of don't do that, that's bad.
Yeah.
And don't do that, that's bad takes a lot of effort and a lot of energy and hardly ever is successful.
Thank you. Heidi?
and I have one
Assuming
comment.
These are the last.
I have one comment. I agree with you, what you said. It's very important, right? The issue is very important. I think the industry is understanding the power and democratization of data. And we have to have a seat at the table when this happens. And we need to engage other scientists and computational people because they bring a new skill set in the life science arena, because life science people are not very versed in computational activity, analytics. So you need to get them involved, and it has to be a multidisciplinary effort to really address this democratization issue. And I think that could be a solution.
Thank you. Heidi?
Yep. Assuming this is the last word
Yes,
or my
this
last
is
words, just two things. I think it goes beyond life science companies. We really need to reimagine the whole healthcare system, because the quality metrics used to pay providers are also, first of all, almost all process and not outcomes based. And they're based on population, the overall population as well. So those who treat patients who are maybe more prone to bad outcomes are going to get penalized under the current quality metric system too. And my very last word has nothing to do with data. I'm encouraging you all to get out, use your voice, and vote against some of these crazy things that are going on in our healthcare system now. I happen to live in the state of Florida that is thinking about putting a bill into place that would protect physicians and healthcare companies from treating the LGBTQ community, racial minorities, and women based on moral thoughts and feelings of the providers and the healthcare companies. Please just use your voice.
Thank you. Thank you, sir, for staying with us. The National Minority Quality Forum looks forward to continuing to work with all of you in a proactive way, and I will transition to the next panel.